Good afternoon. This is Dr. James Marion broadcasting live on Facebook, our third Thursday from the Susan and Leonard Feinstein Inflammatory Bowel Disease Center here at Mount Sinai Medical Center in New York City. Today, I have two very, very special guests, two recent additions to our IBD Center, who I'm very eager to introduce you to because of the special perspective they're going to be bringing in an expansion of our services. We're going to be discussing the overlap between rheumatology and gastroenterology, where they meet in inflammatory bowel diseases. Typically, when you go see your gastroenterologist and get Crohn's disease or ulcerative colitis and your joints are aching, they'd say, well, you're going to have to make another appointment and you're going to have to go see somebody else. And what we've realized over the time is that there's been this enormous overlap, not just in the medicines, but it's not convenient to have to come into the city multiple times. So with that brief introduction, I would like to introduce Dr. Abhik Bhattacharya, who is an assistant professor here in our Department of Medicine and one of our newest additions as a gastroenterologist to our IBD Center. We're very, very pleased to have you with us here, Abhik. As you can see, we're a busy service, and it's just great to have an extra pair of hands. So, Abhik, welcome.
Thank you very much.
And our outsider, if you will, our rheumatologist, who is now also a part of our larger IBD family, is Bahar Moghaddam. Bahar, Dr. Moghaddam, it's a pleasure to have you joining our IBD faculty as well.
Thank you for having me.
So I didn't want to spoil too much, but, and we'll get to the details of this in a minute. Maybe I'm going to have you start with this one, Abhik, and please chime in, Bahar. When we talk about extraintestinal manifestations of Crohn's disease, what do we mean?
Yeah, that's a very good question, and thank you for the fantastic introduction. So as most people know, inflammatory bowel disease includes two major disease spectrums, which are Crohn's disease and ulcerative colitis. Now, we all know that these are autoimmune diseases of the GI system, which means your body cannot differentiate between itself and something foreign, so it keeps on attacking itself. Now, most of the times it will attack the GI system, but ever so often, it can also attack the systems which are present outside the gastrointestinal system, also known as the extraintestinal manifestations. These are in short known as EIMs. About 25 to 40% of IBD patients will develop EIMs. These include manifestations on the skin, the eyes, the liver, the joints, and about 25% of IBD patients will have more than one type of EIM. So this is quite a significant chunk of our patients. And it seems like the development of one of them seems to increase the risk of the development of a second EIM. And the ones that we see most commonly are probably the musculoskeletal complications, where we have our rheumatology colleagues like Dr. Bahar Moghaddam chime in for help from the outside.
So, Dr. Moghaddam, I think when gastroenterologists have to think about arthritis, it's sort of like asking my plumber to think about carpentry. They nod their head and they sort of, yeah, they know there's something there that they should know. But I love hearing you, because I just got to hear you in our IBD rounds, and your colleague, Dr. Weisendanger, who many of our viewers also know, talk about arthritis in the way that you think about it is really very complex. And there's overlap and things that we can learn as gastroenterologists. So when we say arthritis, I mean one thing, but what do you mean when we're talking about it in terms of inflammatory bowel disease?
For sure. So, you're right. Arthritis is complicated and it's not easy to understand. And as a rheumatologist, when it comes to diseases of the bowel, I probably feel like your plumber with arthritis. So each of us, have our own area of specialty. And, it's nice that we get to work together in terms of managing these diseases, which are not easy to live with. What is arthritis? So arthritis essentially means inflammation and pain in the joints, often associated with stiffness. We know that patients who have inflammatory bowel disease like Crohn's or ulcerative colitis are just prone, because of the disease itself and because of the inflammatory environment, they are more prone to getting arthritis. There's different types of arthritis that go with Crohn's disease and ulcerative colitis. The most common form of arthritis that goes with these diseases is pain in the back and in the sacroiliac joints. So I often tell my patients that, back pain is really common, but back pain that comes from inflammation is the type of pain that wakes you up at night, that you can't sit still with for a prolonged period of time, that you wake up feeling stiff in your back and it takes a while, an hour, 45 minutes to get going. And pain that typically gets better when you move and is worse if you're resting and sort of at a period of rest. So, this happens in around, depending on what study you look at, of 15 to 20% of patients with inflammatory bowel disease may get inflammatory back pain. There are other types of arthritis which can cause pain and swelling in these joints, in the knuckles, in the wrists, in the knees, in the ankles. And these are termed peripheral arthritis, meaning that it's in the peripheral joints. And again, a lot of times they present with pain, swelling, and morning stiffness. So as a rheumatologist, what I would do is, work with the IBDologist, one, to see if these are happening for a different cause, because there are people who can have different diseases, and arthritis can happen with many other diseases aside from inflammatory bowel disease. So it's important to get that part of the picture complete, but it's also important to work with the IBDologist to see, whether these symptoms are concurrent with the inflammatory bowel disease. Are the patterns of flare in arthritis following the pattern of flare in the Crohn's or the colitis? And how do these things relate to each other on a longer timeline and spectrum?
Yeah, well, that's terrific. And I think, one of the controversies that we struggled with, Abhik, in our own community of IBDologists is, are the joint symptoms a premonitor of a flare or the other way around? What role do NSAIDs play? If they're starting to take NSAIDs for joint symptoms that are a premonitor, then is it the NSAIDs or the IBD that are leading to some sort of a flare? So the other reaction I'd have to what you just said, and why I'm so excited about the initiative that you two are going to spearhead in our IBD Center, is that just the number of patients who say, I didn't know my joints were related to this. And nobody had ever asked me that question, because again, they're in a plumber's office. The plumber's not going to ask about their joists, let alone their joints, right? So, Abhik, why do you think this is so critical to know about? I mean, what is there to gain about us knowing about arthritis, Dr. Moghaddam knowing about plumbing?
Yeah, that's actually a very important question. As you had mentioned, there's many unknowns for the patients. And to be honest, there are many unknowns for us physicians as well. Some of them you've already alluded to. Extraintestinal manifestation can precede the bowel symptoms, can sometimes be a marker of disease activity, even though patients feel fine. And sometimes they may be completely unrelated to the disease activity. And most importantly, they really affect the quality of life of our patients. They affect sleep. They cause a lot of debilitating fatigue, debilitating joint pain, and missed work days. I'm sure many of them have families, they have children, and this can be very debilitating and devastating for these people. So it is very important for us to know for all these aspects. And Bahar can also attest to these. Our treatments can be quite different from the way we look at it and from the rheumatologists look at it. What do you think, Bahar?
Yeah, there's things that I could do for arthritis, and there's things that Abhik or yourself can do for IBD, but some of them are shared and some of them are different. So working together and making sure that we find either whether it's that one treatment which works for all of the EIMs and ticks all of the symptoms off the list, or whether it's in collaboration and that I could offer something complementary to what they would get at the IBD Center. It kind of depends, and it's really, I'm sure Abhik would agree that it's a really individual decision per patient, and depends on where the arthritis is, what other extraintestinal manifestations do they have, and what are their wishes and treatment for their disease as well.
Yeah. I think one of the advantages that we all are very aware of, I mean, you youngsters, maybe even are aware of this, is how parallel both of our fields have been in both developing and doing the hard clinical research on, and then exploiting the biologics, right? So the list of medicines, I do the medical letter once a year for IBD, and I tell the editor, I said, just send it over to the rheumatology group, because it's the same list for the most part. And that goes back to the 30s when you think about it. I mean, sulfasalazine, that was invented for rheumatoid arthritis, and it still has some benefit there, but it helps with ulcerative colitis. So this is a long collaboration, but it's nice to see it coming to a head as we start to establish this clinic. And Bahar, if you could tell us a bit about what this IBD Rheumatology Clinic collaboration is going to be called and what it's going to be like.
So we're very excited. Our current name is the IB-DART Clinic, the IBD and Arthritis Clinic.
Catchy. I like
very
that.
Catchy, yeah.
I like it.
Like sharp and precision medicine, really. So what it entails is that for now, it's once a month. It's the second Tuesday of every month. And what we're doing is that both Abhik and I are seeing patients, not simultaneously. So when a patient comes in for their appointment, they either see Abhik or myself first, and then we switch, they see the other provider, and then we come into the room together, sort of discussing with the patient our joint assessment of the situation, and sort of, one, making sure that, is the arthritis related to the IBD? If so, what can we do to optimize it? In addition to all the medical therapy that we do, there's a lot to be said about the role of physical therapy and exercise. So I try counseling on that as well. And then we follow these patients either in the IB-DART clinic, or, if they already have other IBDologists, we send them back to their own IBDologist with sort of peripheral follow-up. And similarly, many of these patients may have rheumatologists in the past. But I think, the benefit of this clinic is that we're having a discussion together, and instead of, emailing back and forth, it's just so much nicer to have that discussion in the room together. We just had our first clinic last month, and I'm sure Abhik can talk to how well it went. I thought it went well.
How did it go, Abhik?
Honestly speaking, I mean, apart from the things that Bahar has already mentioned, I would say the other very important factor that I garnered from this was education. I mean, as an IBDologist, the things that I've got to learn from Bahar when it comes to management of things like enthesitis, which is like inflammation at the insertion of the tendon, or things like uveitis, what kind of medications can we use, which is the best biologic medication. I took one thing back from her in one of the clinic, and I've been telling that to everyone inside the clinic about, and it's just fantastic. It rejuvenates a spirit of collegiality. It's wonderful to be in that kind of setup. Honestly, I would recommend anyone to come and see us in clinic once and see what we're doing to help our patients.
Yeah, so how do we refer patients to this DART clinic, the IDART clinic?
IB-DART.
IB-DART, sorry.
IB-DART.
So yeah, fantastic question. So if you are within the Mount Sinai system and you have a primary gastroenterologist or a rheumatologist, or even probably a primary care physicians, they can directly email us, or they can call the IBD Center and have themselves scheduled with us to be seen in clinic.
Right.
That's one way of doing it. If you are outside the system, you can call the IBD Center give your diagnosis, tell that this patient has both IBD issues as well as rheumatological issues, and then we will triage at the outset itself and have them funneled over to our clinic. Now, having said that, I want to make it very clear, we are not trying to step on anyone's toes over here. They still maintain their primary physicians, their gastroenterologist or their rheumatologist. We are just acting as a consultative service, and hopefully we can help guide the treatment just a little better. I mean, everybody is an excellent physician in our setup and probably outside. It's just the finer edges that matter, and that's what we are providing, to be honest.
Wow, well, that sounds very exciting. And I really am pleased that you have come up with this idea. I think it is a sort of natural culmination of the decades of collaboration between our two divisions that, you know, I think I've always been very proud of, and it's nice to see it really put into a brick and mortar setting that will serve our patients. And as you say, Abhik, it's going to make us better doctors on both sides, I think. So the goals for this, Bahar, any thoughts for the future in terms of what you see coming out of this? Yes, we're all going to be grateful for your help and your consultations, and as we always have been, but now you're going to have a lot of substrate. You're going to have a lot of patients. And what do you think the future might bring with this type of collaboration?
And Abhik can, just cut me off or add on as you see. I think in the long term, our first goal is for patient-centered care and for all of our patients to be able to treat multiple comorbidities sort of as a one-stop shop, if you will. But there's also tons of opportunities for research. Once we do have a cohort of patients with IBD and arthritis established, we hope to be able to, take a look at how have they changed clinically over time? What are the symptoms that are more prominent, and how do these respond to various medications? And also we'd be able to take a look at, who are the people who do get arthritis more commonly? Is there anything genetically that makes them more prone? Is there, how is it relating to their underlying disease activity? But for me, the first goal is patient-centered care in a multidisciplinary setting, and the second is how it would contribute to our ability for clinical research and participation in future clinical trials.
Yeah.
I totally agree. Yeah, I totally agree with her. I think the most important thing apart from the patient-centered care is to figure out what the natural history of the disease is when patients have inflammatory bowel disease along with extraintestinal manifestations. As I've alluded to earlier, a quarter of our patients are afflicted by these conditions. But very importantly, also looking at the mechanistic aspects. At the molecular level, what's happening? Sinai has a rich tradition and a rich history of collaboration with our translational or our basic science research platforms. And this is a unique and fantastic opportunity which we are exploring at this point of time. We are going to be setting up prospective registries of patients across centers of the United States, where we will be inducting patients into looking at the long-term history with different intestinal manifestations. And as she said earlier, possibly clinical trials, looking at medications which can affect both of them optimally and without going through the limited armamentarium of medication that we already have.
Wow, it has been so great to have both of you here. And I look forward to getting an update in the near future about how things are going. For our patients who are watching, Dr. Bhattacharya mentioned the way to plug into this clinic if you're in-house is going to be through either calling the IBD Center directly at 212-241-8100 or going through the MyChart system. You can schedule there. And I think there's going to be some accommodations for some ZocDoc scheduling as well, from what I hear. So, and we'll have that information below in the comments section. So this is Dr. James Marion concluding, and I want to thank Dr. Bahar Moghaddam Just wonderful having you here. Welcome to the IBD Center, and really just completely thrilled with this initiative. And Dr. Abhik Bhattacharya, you are welcome to Mount Sinai. Really, just you're new, and we're just thrilled to have you. And you've already taken great care of my patients, and I am thrilled to have you here as our newest IBDologist. And congratulations on this collaboration in advance.
Thank you very much, Jim. Thank you.
This is Dr. James Marion thanking all of you for viewing our third Thursday Facebook Live taped on Zoom at the IBD Center. I think at some point we're going to start doing these in person again now that the vaccine is penetrating the population and the numbers are starting to drop. I want to encourage all of my viewers, if you are able to, when it's available to you under 1C, please get vaccinated. They're safe and effective in IBD, and you can look at one of our previous Facebook Live broadcasts if you want more details. In a discussion I had with Dr. Dubinsky, and the Mount Sinai websites are filled with great information on this. So thank you again for attending. Dr. James Marion for the third Thursday live at the IBD Center, and I look forward to seeing all of you next month on the third Thursday of March. Thank you.